So I'm going to talk about a couple of things, and I'm going to focus in particularly on the mitral valve team, or the structural heart valve team. We've heard a lot about that. So what about mitral valve intervention? When do we intervene, and what do we do? And you've seen a lot of this, and there's a lot of overlap in some of these talks, so I'll skim over stuff that's been spoken about before. But if you've got someone with primary mitral regurgitation and they're a young person, they may not be very symptomatic, you have to have a fairly good have a fairly good reason that you're going to operate on them. You want to be comfortable that you're going to be able to achieve a repair, and the guidelines are such that you want to have a 95% chance of repairing that valve with a very low expected mortality or no expected mortality. So you want to be comfortable that you can repair that valve and you can do it well and get a good long-term result. As for the secondary MR, the whole day has been about secondary MR, and more we're looking to percutaneous options for secondary MR because perhaps surgery hasn't been as successful as we would like it to be. So what about the mitral valve team? They're all experienced teams, and we've seen examples of them in these excellent presentations beforehand, but they're anaesthetists, they're perfusionists, they're cardiologists, they're nurses. We often forget the nurses, and they're surgeons. And the surgeons are at the bottom there. They're only a small part of the team. The rest of the team is very important, and it's important that they work together and they're cohesive. But there are teams. What are the difference between various teams? If you look at the top two, they all look like surgeons. They all look like theatre nurses. But what's the difference between them? What about the tennis players down the bottom? They all play tennis, but there's clearly some differences between those tennis players. And the difference is practice. And if you've probably all read the Malcolm Coldwell's book, Outliers, which talks about 10,000 hours of practice that you've got to put into mastering any technical exercise. And that's the same in surgery, and that's the same in structural heart. It all comes down to practice and volume. So for mitral valve surgery, what do you need for a successful program? You need good imaging, you need perfect imaging, you need a standardized setup, you need a competent team, and you need to be able to deal with complications. And most importantly, you need a sufficient caseload, because unless you're practicing, you're not going to get good at it. It's as simple as that. And there's a paper that was published by David Adams and his group, and I've heard they might be actually listening. And so David's one of the gods of mitral valve repair, and he looked at the rate and the probability and the incidence of repair in New York State. It's all related to volume. So the more repairs you do, the better you are at them. The more successful you'll get, the more chance you'll get a successful, durable repair, and the more chance you'll have at avoiding complications and, in fact, your mortality rate. And you need to do at least 25 to 30 mitral valve repairs a year to even be acceptable. And I'm not talking about minimally invasive or robotic or open, if you want to call it. I'm just talking about repairing the mitral valve. David Adams does them through a stenotomy. I have no problem with that, as long as they're doing enough volume of them to do them well. And of course, he is. So you need to do, as I said, 30 cases a year to be good at it, and to get acceptable rates of repair and minimal complications. If you look at the MBS data in Australia, there's less than 5 surgeons. In fact, I'm probably being generous, that do more than 25 cases per year. So there's just not enough mitral valve repairs in Australia for everyone to be good at it. So the data suggests, from David Adams' paper and our data, that we should concentrate this sort of work in centres of excellence. And that's what today's about, the mitral valve team or the structural heart team. If you look at learning curves relating to complications in one institution in Germany, you can see the complications coming down as their experience grows. And what happens at this point? One of the experienced surgeons leaves and goes to another institution, and then the complications and the repair rates worsen. So for minimally invasive surgery, it gets a little harder. You need to have done at least 200 minimally invasive mitral valve procedures before you get these acceptable rates of adverse complications. So at St. Vincent's, we've done a lot of mitral valve repairs. I've done a lot of mitral valve repairs in conjunction with other procedures. and I'm over 500 minimally invasive mitral valve repairs. So we're comfortable doing them, and it's all a teamwork. So much so that we can broaden our experience into other procedures of the atrium using a minimally invasive approach. So I'm not going to dwell on these numbers because we've seen them in a previous talk. But what has happened between my first 200 and my 500 now, repair rate's still very good, and we're predominantly talking about degenerative valve disease, but I've certainly got quicker. And I think that's important when you're talking about a surgical procedure. We've heard people talk about morbidity with surgery. If it's going to take you all day to do an operation, you probably shouldn't be doing it. You need to be quick, you need to be efficient, you need to spend less time on bypass and less time with the heart cross-clamped. We can do all types of repairs, 1 leaflet, 2 leaflets, rings, bands, any other, we can put neo cords on, we can shorten cords, we can do an edge-to-edge repair if we need to. And there are also concomitant procedures that we add into a left atrial reduction. So if we have people with very large left atriums, we can reduce the size of that, which is said to help in the post-op recovery, recurrence of atrial fibrillation. We can do ablation procedures. Something that we're doing a lot more of more effectively is closing the left atrial appendage. And the latest thing that I'm using is using these AtriClips, which are excellent. And if you can put them on through the transverse sinus underneath the aorta, they're very easy. They're much better than previous ways that we used to close the appendage. And you can see here in this little video here, you get a really nice result with the appendage closed there. So I'll just move through this. Results are all excellent. We wouldn't tolerate. We may tolerate mild in certain patients coming off the table, but I think these days in our later experience, we'd even go after that to improve that. So everyone gets a good result. So what about the anatomy of the mitral valve? Just a quick overview, and we've heard this before. You've got the anterior leaflet, posterior leaflet, the subvalvular apparatus, the cords, and the papillary muscles. And we'll talk more about those as we go through some surgical videos. We'll start off with a bit of degenerative work in relation to mitral valve repair. So these are the type 2, where there's actually something wrong with the valve. And we heard in an earlier presentation, you can have something wrong with the valve, or you can have something wrong with the atrium or the ventricle causing the regurgitation. And we've seen this before. So what about the mitral valve team? So here's an example of what we do every day when we do a mitral valve repair. And it'd be strange for us to have a day where we're not doing a mitral valve repair. So you see there's a fair bit of discussion. You can see my anaesthetist here, Andrew Jackson's going through the preoperative assessment of the valve. We're having a close look at what we need to do to it. There's a surgeon that's come and trained with us from New Zealand that is going to go over and start the program. In the bottom left-hand corner there, you see once we start the operation, it's a fairly smooth, cohesive procedure. And these surgeons, these nursing staff, I'm feeling old now. I've worked with them for close to 12, 13 years. So it's a well-oiled machine. If we look at hone in on a particular case, this is Marty Shaw, who's one of the anaesthetists that I've worked with for over a decade and is involved in the structural heart program. We're starting to assess a valve. So this is a valve that's prolapsing. And this is what we do. We spend a fair bit of time working out what we need to do to the valve. And what he's doing now is measuring the heights of the posterior, posteromedial and the anterolateral cords. We can see this is a posterior leaflet P2 prolapse. And the important thing about this is it's a big valve, it's a big man. So we want to get a good repair that's going to affect, obviously it's going to stop the mitral regurgitation. It's going to be a solid repair, so it's going to have a good long-term durability, but it's also going to be a hemodynamic repair. So in young, large, fit, active people, you don't want to put a small annuloplasty ring in and narrow things down. So what Marty's doing here is we're working out based on annular measurements, on the cord height, on the leaflet lengths, on C-sep distance. So we want to avoid SAM. We're working out how far we want to pull that posterior leaflet down, where we want to position those cords onto the pap muscle. And then Marty's telling me to probably close that cleft there between P1 and P2. So cannula placement in the minimally invasive settings, all done once again as part of a team. So Damien Boyd's the second anaesthetist there, and he's putting the neckline in. That's done. All the lines are placed with echo guidance, so he can see the wire. The second nurse scrubs up for placement of cannulas. And that's a neckline going in. And Marty and Damien are talking throughout the whole procedure about where the cannulas are placed and that they're in the right place. We check them, we do bubble studies to make sure they're in the right place. And once we're happy with that, we move on with the femoral cannulas. So similarly, we're looking at the wires coming up the IVC into the right atrium. And we do the same thing with the aorta. We make sure the wires are present and positioned in the aorta, and there's been no damage done to the aorta. I'll keep moving through these. So what was the strategy with this repair? We're going to put a large ring in. As I said, he's a large man. We're going to put 20 millimeter cords to the P2 segment, and so we'll just go through that now. So you can see there's a ruptured cord. What I'll do now, and this is through a minimally invasive setup, so you've got a very nice view of the mitral valve. It's a misconception that you don't see the mitral valve very well, but you see it beautifully. It's right in front of you. It's on FOSS, if you like. So you can see that large P2. That's too much to resect, in my opinion. You'll end up chopping too much of the posterior leaflet out. You'll end up having to slide the remaining leaflets across, and consequently, you'll end up with a small ring. And if you've got a big 6'3" guy who runs triathlons on the weekend, you don't want to put a small ring in him and give him some functional mitral stenosis. So there I am confirming the cord length that Marty's given me. I've already made these cords. I made them based on the preoperative toe because we knew that they needed to be 20 millimeters. So I'm placing the first set of cords to the posteromedial pap muscle there, to the posterior head of the posteromedial pap muscle, and then the second cords to the posterior head of the anterolateral pap muscle, and then take their loops, those cords, then take a second stitch through the loops, and then bring them up through the leaflets. So the posterior leaflet P2 gets 4 new cords from either side of the ventricle, from both pap muscles, and they're reinforced by going around the tips. So once the neocords are tied down and put in, we cut them, and as you can see already now, the valve's competent. So that posterior leaflet's staying down. So the next piece of the puzzle is to put the ring in, and the ring's important. The ring stabilizes the annulus, and it brings those leaflets together so you get a good coaption. So once the ring's in and settled down with, we use core knots now, which are the greatest thing since sliced bread. They don't have to tie those. They get a very nice, neat, clean repair. And that doesn't need to take too long. It's a fairly complicated repair, putting all those cords in, but it took under an hour. And what was the result? So you remember what we were aiming for in the middle here? We're aiming for a valve where the posterior leaflet was still working to a certain extent, but plenty of coaption. So you can see there's a large amount of coaption, and that's going to bode well for a good long-term repair. And you can see the ring there, and there's obviously no mitral regurgitation. So before and after. So what about ruptured cords to the posterior, to the P3 segment? Similarly, that can be fixed with cords. I'll move through this fairly quickly because it's a similar sort of procedure, but this time we just need cords to the posteromedial papillary muscle. So once those are placed in, we bring them up through the ruptured flailing P2 segment, which is over here in the corner, which is sometimes hard to resect. So particularly if you don't have support either side of the leaflet that you're resecting, you want to preserve it and use cords. So once again, the ring goes in, we test it, we get a good result. What about anterior leaflet prolapse? So they often come to me. I see people for a second opinion. They've been told that this valve needs to be replaced. Once again, they're young, active people. Last thing you want to do is put a mechanical valve in if you can avoid it. And this looks like a fairly straightforward thing to fix. once again, it's all worked out on the preoperative toe. We put the retractor in. This time we're going towards the anterior heads of the papillary muscles, so that the cords will reach up to the anterior mitral valve leaflet. I'm a sort of a belts and braces guy. Some people would just put 1 or 2 cords in, but I put at least 2 cords coming off each pap muscle, going to each segment of the anterior leaflet. So you can see the cords tied down there. Similarly on the posteromedial, or it's the posteromedial, the anterior head of the posteromedial pap muscle. And these are commercially available preformed cords, which come in different sizes, and they're really good. But unfortunately, I think due to COVID, there's a bit of a backlog on them. So once again, the cords are brought up to the anterior leaflet, come through the anterior leaflet, tie them down. So you can see the 4 cords going there to the anterior leaflet. Once I've tied them down to secure those heights, I go back around the leaflets to make sure I get a nice firm hold on those leaflets, and I tie the knot underneath the leaflet so that you get a nice clean repair without knots in the orifice. The ring goes in, and you can see that that's going to work. You can already see the anterior leaflet sitting down there nicely. You can probably just make out a hint of blue there. We mark the leaflet with, we draw on the leaflet so we can assess the coaptation zone. And so that gets a good result. We do resect leaflets, we do resect areas. This is a gentleman I just did last week. So he had a quadrangular or partial quadrangular resection just of the P3 segment and a 32 ring. And sometimes you don't need to do a complex cord repair or subvalvular repair, and you can just remove the part of the leaflet that's prolapsing, and you can see me cutting that out there now. Once again, the view of the mitral valve is very good. I actually find the view of the mitral valve for a sternotomy a little bit harder to get at these days, because with the minimally invasive approach, you're looking straight at the mitral valve. So you can see it in all its glory. We then repair that with a Gore-Tex suture. And once that resected area is repaired, the ring's placed. Tie the repair down, place the ring, and test the valve. And that shouldn't take too long. You can see the clamp time down there of 40 minutes. So that's type 2. What about type 3 or type 1? And this is what we've heard a lot of talk about today. The atrial functional regurgitation, or the atrial secondary regurgitation, and the ventricular functional regurgitation. This is an echo paper, which is a really nice description and covers a lot of the aspects of, in particular, atrial functional regurgitation. So these are patients, and we've talked about it, who've got atrial fibrillation causing a particular pathology of the mitral annulus, leading to mitral regurgitation. And it's different from functional regurgitation, as we've heard today. So in the normal valve, we have coaptation of the leaflets below the annulus. We have the ventricle not dilated. In functional ventricular regurgitation, the problems with the ventricle. So we have a dilated ventricle, be it through a cardiomyopathy or through an ischemia, aneurysmal dilatation of an ischemic ventricle. The leaflets are tethered and pulled down. In atrial functional regurgitation, the ventricles are often normal. The leaflets of the valve are actually normal. The problems with the atrium, and as we've discussed in previous talks, the leaflets coapt at the level of the annulus. They're just pulled apart, and so it's a different mechanism. And it does change. The annulus of the mitral valve changes with atrial fibrillation. It becomes larger. It becomes flatter, and it becomes more spherical. So there's actual change at the mitral annular level. And there's also, I've left a slide out here because it also, atrial fibrillation has been shown now to histologically actually change the mitral valve. So it becomes thickened and somewhat elongated. So here's a nice example of the two different mechanisms of secondary functional regurgitation. So when it's atrial, the first thing is you must treat the AF. If you can get them back into sinus rhythm, then you'll go a long way to dealing with the mitral regurgitation. If you have a failed ablation, 82% of them will go on to have moderate or moderate severe mitral regurgitation. And we've touched on this, and maybe we can talk about later. Surgery probably does improve the outcome. So as I've mentioned, the annular plane is flat. The leaflets coapt along that annular plane. And in that situation, from a surgical point of view, an annuloplasty works very well. And there's some early data coming out showing that you can reduce hospitalisation and heart failure symptoms if you deal with the mitral regurgitation associated with AF. And as Greg has pointed out in an earlier talk, these are beautiful cases. And if we saw very nicely from the previous case, that was an atrial functional regurgitation that was treated beautifully with an atrial clip, with a MitraClip. So that's a good example of that. What about ventricular functional regurgitation? This is a bit of a tough nut to crack. So these are the people that have a poor ventricle, and you can see here the ventricle's dilated, it's thin, the leaflets are being pulled down into the ventricle, they're being tented down. We look at this tenting volume, this tenting height, which is how far the leaflets are pulled down, and we know from the data that we're not very good at fixing this. We're certainly not very good at fixing it surgically. Greg once again talked about Bolling's work where he would downsize those with annuloplasties. Doesn't really change your prognosis, but and the mitral regurgitation does recur. At St Vincent's, run the transplant program. We took all our patients off the transplant waiting list and we did mitral annuloplasties on them. They all felt better, but they all ended up having a heart transplant in 2 years or so. So it doesn't change the outcome. So, and importantly, mitral valve repair, so an annuloplasty in these people isn't as effective. So if you look at people with tenting heights over a centimetre or up around a centimetre or tenting volumes of 3 or more, 60% of those, the mitral regurgitation will recur. So they're people that are going to end up having a replacement. So as I mentioned, if you have atrial fibrillation and you have mitral regurgitation that's severe, you will do better having that fixed up, and that whether that's done through a MitraClip or an annuloplasty. This is surgical data showing that that if you repair the mitral regurgitation, you'll obviously get less MR, LA size will come down, atrial fibrillation, heart failure symptoms will be reduced. So it is a good strategy in people with atrial fibrillation. I don't know whether, I think severe mitral regurgitation in and of itself is enough to operate on if they're symptomatic. I don't know whether it should be done for just as a strategy in dealing with atrial fibrillation. So this is a patient with ventricular mitral regurgitation. So you can see there the ventricle is a bit dilated and it's a bit down. You can see here that the leaflets are tethered and pulled down into the ventricle. And when we take the measurements, we see the annular plane up here. You can see the leaflets are all coapting down well below the level of the annulus. All right, so these are the patients we talk about that we've talked about. Can you repair these? And by repair, I mean do an annuloplasty. Can you clip them, or do you replace them? And I think we've got good strategies now related with him. The point is, does it matter? So when you look at the echo pictures of these preoperatively, you think, wow, that looks like a pretty straightforward annuloplasty. We just put a ring around that, squeeze it right down, we'll get a good result. But we know from that previous slide that group of patients, if we do that, 60 to 70% of them will be back in 18 months to 24 months with further regurgitation, because it's a problem with the ventricle. It's not a problem with the valve. So this patient went on and had a mitral valve replacement. That was the plan. It was always the plan. That can be done minimally invasively, no problem. And she got a good result. So what about the percutaneous options? And we've heard a lot about the percutaneous options today, and we've seen some excellent demonstrations of it. And I think that they're really coming into their own in this secondary mitral valve regurgitation group, because they are a tough nut to crack. Surgery's certainly doable, and you can do it safely, but it carries the morbidity of associated with surgery, and you don't necessarily get a good long-term result. So is there some way that we can, and you don't necessarily change prognosis. So is there a better way that we can deal with this mitral regurgitation without surgery? And that's where percutaneous options have come in. And we've talked a lot about the MitraClip and the Pascal, the new clip from Edwards, which we've used a bit at St Vincent's, and we've seen the previous groups. So I won't go on about how the MitraClip works. It's the alpha area stitch. We bring two of the leaflets together. But what about the mitral valve team? So once again, at St Vincent's, we have an MDT every week. We go through pretty much all the cardiological and the cardiothoracic surgical cases in the hospital. We discuss the TAVIs, and we talk about the mitral valve cases. So a couple of the same players in the mitral valve AtriClip in the AtriClip team. So Marty Shaw is the anaesthetist and the echo guy. And as I pointed out earlier, I've been working with him in the mitral valve space for over a decade now. So now we're in the cardiologist's domain. So we've got to put on lead and walk around feeling miserable. And David Muller, Professor David Muller at St Vincent's, he's been the head of the structural heart program there. We work very closely together. We've been abroad and we train together. So we do the MitraClips together with Marty. And here's a couple of MitraClips we did last week. I know you're probably sick of seeing MitraClips, but they're a good procedure. And as we've seen from the excellent team previously, if you choose the right patient and you have the right team and you have the right imaging, you can get a good result. Similarly, this is a patient in their 80s, late 80s, 90s. This is actually a patient that's got a degenerative mitral valve, so they've got a ruptured cord, and you can, if they're not up for surgery, or they're, got some comorbidities, or they're just too old, or you think you can get a good result for someone in their late 80s from a MitraClip, this is a really good option. Similarly, this is another case where we put two clips on, and we've talked about that. So you come in, so you can see the first clips on this on-FOSS view there is there underneath, but there was still a jet medially. And you can just see a little prolapse flicking up there. So we come in with a second clip, slip down into that medial area. And you remember Greg was talking about it can be difficult to image that area because it's right over in the commissure, particularly to get good views for grasping. But we were able to do that. Once again, the echo, the key to this is obviously good imaging and having a great person on the echo. And we can see from the previous talk that Louise is that. So we get a good result. And as we've discussed in previous talks, we've got a mean gradient less than 1. So we're obviously very, very cognizant of the gradient that we leave across any form of repair. This is another one, a prolapsing one, and just to show that it doesn't have to always be secondary mitral regurgitation that you deal with a MitraClip in people who, as we've discussed, people who are not fit for surgery, or we just think might be better off having a quick clip. This is a really good option. And if you have a mitral valve team, they feel comfortable doing that. There's no competition between surgeons or cardiologists. So what happens if a MitraClip doesn't work? And this is, kind of one of its advantages. Most of these patients would tolerate surgery, particularly in a centre like St Vincent's, when we're used to operating on a high-risk patients with the transplant program. We're comfortable doing these sort of cases. So if the MitraClip doesn't work for whatever reason, they're left with severe MR or there's something else going on, you can actually take them off. The MitraClip's got a mechanism where you can actually flick it open, and then you can pair it off. Now, you don't know what you're going to be left with after it, but sometimes you're left with enough tissue to affect a repair, and that can be done minimally invasively as well. So it is a nice option in someone where you think, let's just see if a clip will work. And we've done that often. We haven't often had to remove a clip or go back in, but it certainly is an option. What about other sort of surgical cardiological approaches to the mitral valve. There's the Tendyne one, which we've used a fair bit of at St Vincent's. We were part of the we were the PI we were part of the international trial and the first in man with it. This is a really interesting valve, which is a transapical valve. You go in through the tip of the heart. You seat it across the mitral valve and you deploy it. And you can see in these pictures here. Sorry, I'll just get this going. No, it's not going to quite work. So you can see you can go across the mitral valve. Here's a 3D view of it sitting across the mitral valve. And we open it up, and it has a big fan which sits on the atrial side. And then when it's finally deployed, it sits there quite nicely. And then if you look at this CD picture here, you can see a CT picture. It sits nicely in the mitral annulus. It's actually tethered to the apex with a cord and a button, and it was very effective. I thought it was a good option. It's now reached CE mark on the basis of the trial data being so good, and so it's getting deployed pretty widely throughout Europe at the moment, and hopefully we'll get it back. One of the issues that Louise and I were talking about earlier is the management of this left ventricular outflow tract. These devices they work well at the mitral valve level, but they can impinge on the left ventricular outflow tract. They can push the anterior leaflet up into the LVOT and cause a problem. So take-home messages, mitral valve teams, heart teams are very important. They should be anaesthetists, perfusionists, cardiologists of all ilks. Nurses should be competent and comfortable in all this. And then lastly, the surgeons should be comfortable to work across all aspects of mitral valve interventions. And this sort of work should be, as has been mentioned in a previous talk, should be at centres of excellence or level 1 centres that are doing high volumes, and they'll result in good results and better outcomes. So thank you very much.